Good day to you all, friends and colleagues in Vietnam. In this short lecture, I'm going to address you on the topic of biomarkers for early diagnosis of hepatocellular carcinoma, paying particular respect to the aspect of this problem in developing countries. I'm Philip Johnson. I'm a professor of translational research at the University of Liverpool in the United Kingdom, and I have a long-standing interest in liver cancer. So the treatment, as you're probably all aware, of HCC, which is what I'm going to call the topic today, is predicated on early diagnosis, which is achieved by screening or surveillance. The perception of clinicians is very simple. Large or late HCCs are incurable and rapidly fatal. On the other hand, if they're picked up early, small or early HCCs have the potential to be cured by surgery, transplant, or ablation. So if screening can deliver small or early HCC, then the prognosis should be improved. So this is the basis of treatment for HCC. The epidemiological perception is slightly different, and you should be aware that from the epidemiologist's point of view, the aim of screening is to decrease disease-specific mortality. So surveillance specifically aims to reduce disease-specific mortality, and it does this by permitting early diagnosis when curative treatment is an option. And by curative, we mean lesions below 2.5 centimeters. Who? High-risk patients, particularly those with cirrhosis. When? 6 monthly. How? Ultrasound examination. But you should be aware that there are severe limitations with ultrasound, and the EASL guidelines notice, as I've written here, performance characteristics have not been well defined for cirrhotic livers. Some patients, particularly those who are obese, are not good candidates for surveillance despite their risk. As well as this problem for ultrasound, ultrasound requires an infrastructure, it requires expensive equipment, experienced operators, and has other significant limitations. For this reason, we consider that serological biomarkers, the topic of my talk today, may be the way forward, particularly in developing countries. So we're going to look at 3 biomarkers very briefly: alpha-fetoprotein, the GALAD score, and the AMAP score. Starting with alpha-fetoprotein. The role of the biomarker alpha-fetoprotein in surveillance has been extremely controversial. I'm not going to go into any of that today because we don't have time. However, in the most recent and most detailed analysis, which was published by Singhaal's group in 2018, it was reported that the sensitivity of ultrasound alone is 45%. But if you add AFP, it goes up to 63%. So ultrasound alone picks up less than half of all the early HCCs. And nowadays, most, but not all, clinical guidelines suggest ultrasound for surveillance plus or minus alpha-fetoprotein. We now move on to ask, could other serological biomarkers help and improve on AFP? Herein, we talk about GALAD, because this is the next stage in improving on alpha-fetoprotein. What is GALAD? In GALAD, we use 3 established blood tests that have been widely used in Japan for diagnosis and surveillance for many years. The 3 biomarkers that we use are alpha-fetoprotein, an isoform of alpha-fetoprotein known as L3, and a chemical related to prothrombin called des-gamma carboxyprothrombin, or DCP. So why do we choose these three? We use them because they can be measured on the same system. They are all FDA approved for HCC risk. They are stable and well characterized. And most of all, we have extensive and well annotated data that is available to us. So what is the GALAD score? GALAD stands for G, gender, A for age, L for AFP-L3, A for alpha-fetoprotein, and D for des-gamma carboxyprothrombin. Putting this acronym together, we get GALAD. It was built and validated prospectively in the United Kingdom and then validated internationally. This is the formula. It looks frightening, but in fact, you can calculate the GALAD score very easily from many calculators that are available on the web. The key features of the GALAD score are that it was developed by very rigorous statistical methodology. All the variables in their continuous form. We don't use cutoffs. So you put the absolute value of each of these variables into the model. And after we've done that, then we extensively validate the model, both internally, that is within the United Kingdom, and externally, that is internationally. And if you want to read the original paper, it's published here. We assess the value of the biomarkers by the area under the ROC curve. You'll remember that if the test is completely useless, the area under the ROC curve is 0.5 and the line goes straight across like that. If it is perfect, it goes straight up and across and the area under the curve is 1. You can see here that the individual biomarkers have good areas under the ROC curve. But when you combine them, you get this solid blue line at the top and the area under the ROC curve goes up to 0.97, which is remarkably high. We have validated this model in several different countries and get the identical results. The improvement over the individual biomarkers is modest, but it is very consistent and it has been replicated internationally. Most recently, it was replicated from the United States in a study which involved most of the major hepatology centers. These were the results. You can see that in early and overall, the area under the ROC curve was confirmed to be remarkably good, 0.95 and 0.92. And the investigators stated in their discussion that the outstanding performance of GALAD was confirmed in an independent multi-center US cohort of early stage HCC and cirrhosis patients. Interestingly, we have data from Japan that allows us to look back in time and see how far from diagnosis the GALAD score was actually raised. So this is on the horizontal axis, time going backwards, and on the vertical axis is the GALAD score. And you can see that those patients who don't develop HCC have a flat curve. This is the patients who do develop HCC. And you can see that the GALAD score is elevated up to 5 years before the cancer is detected in a surveillance program, thus making it potentially very valuable for surveillance. Finally, we move on to the AMAP score, which was recently published in Journal of Hepatology. The AMAP score is based on age, gender, the ALBI score, a measure of liver function, and platelet count. You put these 4 variables into this equation, and it gives a score of up to 100 that reflects the risk of HCC. It was built on a very large cohort. This is the training cohort, and you can see that those patients in the high risk group do indeed have a high cumulative incidence of the cancer, This is the medium group and this is the low, and it was validated in an independent data set down here. So we can classify patients as low risk, medium risk, or high risk. Recently, we've looked at this within a prospective surveillance program. I've not given you any reference as to where this comes from because it's not yet published. But you can see that in the low risk AMAT group, large numbers of patients, only 1.3% during the course of the study developed HCC. In the medium group, it was 10%. And in the high group, it was 37.4%. So this looks very promising. So in conclusion, using simple, old and reliable blood-based markers, we can diagnose HCC accurately at an early and treatable stage. AFP appears to be the key. Prospective validation studies are ongoing. All outputs can be easily generated from an online calculator. And if you would like to look at the website where all our models are placed, this is the link. The GALAD score is likely to be routinely available in clinical practice shortly. The AMAT score can be easily available from routine clinical investigations. Such models may be attractive and practical in surveillance within developing countries. Thank you for your attention.